as Malunited Intertrochanteric fracture. So I have designed this presentation in 3 sets of questions. What a patient will say and what you have to say, you have to ask him, and what you will do, and what an examiner will expect out of you. That is the first part of the presentation. Next is when you will do what in the management aspect. That will be the second part of the presentation. And the third will be how to do the management. That is when you will do the management and how you will do the management. That is the way in which it is designed. And it is just like a ground plan about the case. I will just walk through you through the case, and I will tell you what all things you should not forget. And since it is exclusively made for clinical case presentations, I have made it in such a way that it is just like a case presentation, and I will remind you of all the points which should not be missed when you are presenting a case of Malunited Intertrochanteric fractures. We'll go through the presentation. First, what? 30 things which you will see here. First, what the patient will say.
Muthu Sathish, sorry.
Any symptomatology in hip can be classified in.
Sorry to interrupt. Okay, I think you have to instruct everybody to keep in speaker mode. It's not a screen sharing. Is this a screen sharing, or you want to keep everything in speaker mode? In the speaker view mode.
Okay, sir. This is normal screen mode, sir. Screen mode.
The speaker.
Face varudhilla sir, and the mode.
Okay, ma. Right, thanks, sir.
Now it's clear, sir. Everyone make it in speaker mode so that I'll be visible and all the content will be visible.
Yeah.
Okay.
So everybody has to.
So as I said before, any. Is it okay now, sir? Okay, I will continue with this. Any symptomatology in hip will be presenting with these 5 classical signs. So in malunited intertrochanter, will the patient have a pain? Since it's a malunited intertrochanter, pain will not be a predominant complaint. If at all it comes, it may be due to a trochanteric bursitis, which may be presenting as a pain to him. So that will not be a major presenting complaint. Next is limb. Definitely the patient, if he has a malunited intertrochanter, definitely there will be a high riding trochanter and there will be short limb. So he will have a limp on his walking style. So that may be a presenting complaint. Or a stiffness if it is in the early stage of presentation, and if it is a very chronic and delayed case, he will present with any fixed deformities which might be disabling his activities of daily living. So that may be a predominant complaint of the patient. And swelling. Swelling we don't see most common, but even in a thin built patient, if he has a high riding trochanter which is more prominent, which he thinks is the main complaint, even that may even be the complaint of the patient, apart from deformities or limb. So these are the 5 symptomatologies which will present to you as the chief complaint. And you will elaborate on these complaints in the history of presenting illness. And what other etiological leading questions you will ask about. Ask about the history of trauma. And elaborate on it about whether it is significant trauma, how disabling it was, when it was, and what was the initial mode of treatment that was given to it, whether it is attended or not, if at all attended, whether it is natively attended or it is properly treated with a physician. And since it is the region which is more prone for pathological fractures, have a history about a tumor also. And since we are in an endemic zone of tuberculosis, anything and everything may be considered as a TB. So have a word about negative history of tuberculosis. And inflammation, as you all do in all hip cases, about inflammations and all your rheumatoid and all inflammatory arthritic histories you will come about in this way. In the etiology, these are the 4 etiologies which you will ask about, ask your leading questions and write it in the history of presenting illness at the fag end of the history of presenting illness. It is a negative history. If it is a positive history, you elaborate on it and take it up in the presentation. Next, this is what the patient will say. Now we will see what you will do about it. First, these are the 4 things which we will do systematically. First, we will go through the inspection. Before we see, this is what I have given here is not the only thing which you have to see in the patient. These are the things which you should not forget when you see a case of malunited intertrochanter. You can just have a visualization of a patient lying on a bed. Consider him presenting with the malunited intertrochanter. Let's see what you will see in the inspection. Any inspection starts with you say general examination. You say about the build, and nourishment of the patient. Any significant general examination findings, if at all is there, you just comment about it. And then you come to the examination, clinical examination proper of the hip case. So you start with your spine. Whether you just look out whether there is any exaggerated lumbar lordosis, whether light is seen from the opposite side or not. If at all, if it is seen, you just comment saying exaggerated lumbar lordosis is noted. Consider if at all it is there, there must be a finding of flexion deformity in your examination. And then you come to the hip side. You will see the ASIS. Look at the level of the AS in both the sides. In any hip pathology, whether it is neglected or natively treated, whether it is presenting with any deformities, the classical two range of movements which will be restricted are the abduction and internal rotation. So definitely the opposite deformities will come up, adduction deformity and external rotation deformity. So if a patient has adduction deformity, considering this case as a malunited intertrochanter, then the ASIS will be higher up. So you must comment about it in the inspection after exaggerated lumbar lordosis. So you will comment about the ASIS. Then you look down. You look at the attitude of the lip. You just comment about it, how it is. And the deformity, if it is very veiling to the naked eye, you can say whether the petala is facing up or facing the corner of the room. It's saying, which is indirectly meaning about the external rotation deformity he is having in the lip. And comment about the shortening, which is visible. Look at the level of the feet, how short it is appearing. So you can say it is considerably short compared to the other side, something like that. And then you can also comment about wasting. Since he's a chronic or neglected or failed case, there will be definitely wasting of either the thigh segment or the leg segment. You can even mention if it is very obvious in the thigh segment, you can say thigh segment is more wasted compared to the opposite side. And proceed with the inspection findings of the hip examination proper. If you come to the hip examination proper inspection, it will start with the hip fullness of the star-cross triangle. You can start from there. If it is very obvious, you can say, but since the malunited intertrochanter, there is no pathology involving the hip joint, so nothing will be seen there. So there is no fullness, and then you can even say like this: I have examined the patient in a lying down posture and in the standing posture, from the front, from the sides, and from the back, and I'm giving my inspectory findings. You can say like this, and then proceed with the presentation. You can say there is no fullness in the star-cross triangle. You can comment about it. If there is a trauma, and if there is if at all it is a failed case, you can see the scar, or if it is having any complications with it, you can see the sinuses or dilated veins about the lateral aspect of the trochanter. So you can comment about that. And then inspection in the posterior aspect, you can say you don't find any, apart from gluteal muscle wasting and level of the PSIS, you don't have any positive significant findings in the inspection. Okay, then we can move on to the palpation aspect. In the palpation, if you see, you will first come from the above. You will confirm all the findings which you have said in the inspection. If you have said about exaggerated lumbar lordosis, you have to say that it has been confirmed in the palpation. And by Thomas Willig raising test, you have to make sure how much flexion deformity is there in the hip. And then you come down, confirm the level of ASIS, say how far, whether it is high or low. And then if it has an adduction deformity, it will be high. So say that it is higher. And then you come down and then say, start from there. There with warmth, tenderness, which will not be there in this case. So there is no warmth or tenderness. And then what you will say, definitely this is not an ecophumus case. So you will have a vascular sign of Naruto will be negative. So then you will go to the lateral aspect where you have the predominant findings. In the lateral aspect, in the palpation, you will see either the irregularity or broadening or thickening of the trochanter, which will clinch you to say that it is a trochanteric fracture which has happened before due to the significant trauma in the history. So this is the place which you will stress upon with the examiner that you have a positive finding and it is significantly correlating with the diagnosis. So you take time, explain in detail that the trochanter, it is broadened, widened, and it is irregular. And if you have any mass, if there is a callus and it is continuing somewhere, and then even that may present as a fullness in the star-cross triangle also sometimes. So these are the findings which are unique to the case, but in general and common, you have findings in the lateral aspect as thickening or broadening or widening. Then we can go in the posterior aspect and confirm the levels of the PSIS, and then there won't be any significant palpatory findings in the posterior aspect. So this is the way it goes. We will see what are the things you have to say in inspection. Inspection and attitude, you can say about the gross shortening, you should not forget that. If at all, if it is a failed fixation case, the surgical starts in the comment about the status of the scars and healing nature, all you have to comment about it. And on the inspection, you won't forget to say the obvious deformities which are visible. These are the inspector findings which you should not miss. And in palpation, if at all he complains of any tenderness in the trochanter, either due to bursitis or something, you can comment about in palpation. If at all it is not there, you need not say about. During palpation, you can say about the you make the digital Bryans and say how far it is short. Although you will do a Bryans in the measurements and say how much centimeters it is short. Yeah, some have the habit of saying it is a digital Bryans in the palpation and saying it is considerably short compared to the opposite side, this much finger breadth or something like that. And irregularities. This is the part where we have the most of findings confining to this diagnosis. And then movements and measurements. You come to movements and measurements, first you say about the fixed deformity. Either he is having a flexion deformity or adduction deformity or external rotation deformity. Say the deformity, how much, if he is having a 15 degrees of adduction deformity, don't ever say the opposite side range. Just say 15 degrees of adduction deformity and further adduction, how much it is there. That's it. And if it is a fixed flexion deformity, say how much fixed flexion deformity is there, and don't even comment about extension at all. Same way goes to the external rotation deformity also. If at all it is fixed, don't say the opposite side. That's a blunder, and you will be getting a bad impression out of it. So, and make a habit not to you consciously say the fixed deformities alone, and then you can make the measurement of apparent into length of the limb. It will be definitely both shortening in the apparent measurement and in the true measurement. And in the true measurement, you have to say how much supratrochanteric shortening is seen by the Bryans triangle, making the Bryans triangle. And then some have the habit of saying gait after the special test. Some will say during the movements and measurements itself, so that it is not getting left off after the special test. So coming to the gait of this patient, he is having a short limb. So, and he is having a weakness of, definitely there will be an abductor weakness, and lever arm will be definitely damaged. So he will have a Trendelenburg gait, and he will also have a short limb. He will be having a short limb Trendelenburg gait. That will be the pattern of this case, and you can confirm it with the exact gait that is given to you, and then you can proceed with the way of the gait he is having. This is to do with the movements and measurements. Coming to the special test, Trendelenburg, just make sure that if he has a coronal plane deformity, you need not comment about Trendelenburg. Even you can say, sir, there is an adduction deformity, fixation deformity. So there is no point in doing a Trendelenburg. So I didn't do a Trendelenburg. They might ask you, did you do, if you say he is not able to stand or something like that, they will ask you didn't do modified Trendelenburg or something like that. If he has a coronal plane deformity, there is no need to do a Trendelenburg. And you can even mention that, sir, I didn't do Trendelenburg because he is having a coronal plane deformity. You can say like that. There is no harm in saying that. And telescopy, because since you are saying it, since it's a malunited fracture, and there is no room for movement in the fracture site at all. So telescopy will be definitely negative. So you can strongly say that it is negative, and that is why you are saying it is a malunited fracture. Straight leg raising, since it is a malunited fracture, there will be a transmission of movement from the proximal to the distal end of the fracture, and hence you will have an active SLR. He will be able to do an active straight leg raising. So that will be possible. These are the special tests which you have to say. And if you are tuned into saying gait after this, you mentioned about the gait. And apart from this, you have to say about the status of the ipsilateral and contralateral hips and knees, and distal neurovascular deficit, lymphadenopathy, and all the routine case findings negative findings which you will say in every case. These are the very classical findings which you should not miss in this case. That is what I am highlighting. I am not saying all the routine things in this presentation. After these special tests, you will make an impression to the examiner that you had a methodological way of examining the case, and you have presented all the cleansing findings out of this clinical examination. Now, any examiner, they will ask you these classical two questions. Okay, doctor, what is your diagnosis and what is your management of the case? They will ask you like that. And diagnosis, we are tuned into saying in this way. You will first say what is an anatomical diagnosis, and then you will say what is an etiological diagnosis. Since he is having an adduction deformity, shortening, and the findings of a malunited intertrochanteric, the presentation is as a Cox aware. So an anatomical diagnosis, what is the anatomical diagnosis we have? We have it as either unstable hip. No, he is not an unstable hip. Next, we have it is either synovitis or arthritis or ankylosis. He is not in that way. So it is a case of Cox aware. So you can say anatomical diagnosis of Cox aware, which is due to malunited intertrochanteric fracture, sir. You can say that. With any fixed deformities which is having, you can say about with this much degrees of adduction deformity and this much degrees of external rotation deformity. You can complete it in that way. So in diagnosis, you will be saying malunited intertrochanter. He will ask you till this part. If your flow of presentation is good, the examiner will not stop you from presentation till coming to the diagnosis. So you will reach to this point. You are saying a diagnosis of malunited intertrochanter. He will ask you why it is malunited. You can very well say that, sir, there is a significant history of trauma. So there is a fracture. And the limb is not in normal anatomical position. It has been malunited, and the straight leg raising is positive, so it is malunited. And hence I say it is a malunited fracture. Then he will ask you why it is intertrochanter. Why not it is a basic cervical neck or something like that. Then you can say, sir, if it is a fracture of neck of femur, there is a more propensity towards non-union and not towards malunion. That's the case in every neck of femur fracture. And the shortening, there will be gross shortening in this case, but which will not be the case in case of neck of femur. So you can say in that way that, sir, the shortening is 3 to 4 centimeters, and it has gone to malunion. So I'm thinking more in terms of malunion of the intertrochanter. And your clinical findings are more in favor of trochanter because you have a trochanteric irregularity, broadening, thickening, and widening. And hence I'm more inclined towards malunited intertrochanter. So you can say it in that way and make sure that there is no doubt about the diagnosis with you. And after diagnosis, he will ask you what is the management. Then you will routinely say, sir, management, I will first take investigations to confirm my diagnosis and then go with the treatment plan of the patient. And then, okay, what is your method of doing confirming the diagnosis? He will ask you, and then you will say, sir, I will take a radiograph, a plain digital radiograph of AP view of the bilateral hips with proximal femur or something. I will say like that, and then he will put you an X-ray. And if it turns out to be like this, you just stick to your findings and correlate how far it is appropriate to this X-ray and interpret the X-ray in that way. First, you just read the X-ray. You just say, sir, this is an X-ray, plain X-ray, plain digital X-ray of an adult male showing a malunited intertrochanteric fracture with sclerosis in the acetabular walls and deformed head, and there is abundant callus seen around the fracture site, and there is a high rearing trochanter compared to the opposite side. You can corroborate all your clinical findings to the radiology, and if at all there is any abrupt change or which is conflicting to your findings, you can try to, you may not just blindly say, sir, I will always stick towards malunited intertrochanter because it is that way. No, you just see and try to interpret how far it is correlating. Even in this case, if you see the trochanter, there are some lucencies in the fracture site. It may not be malunited at all, but still you didn't have any telescopy or you didn't have a negative SLR. So there may be some callus which is not visible in this X-ray, which may be presenting in that way of our clinical findings. So you can still say it is a malunited intertrochanter, sir, but the presentation of X-ray is like this. And then after the X-rays, what all the investigations you will do, he will ask you, and then if you are then you will consider in terms of how long it is, how long the malunion has been there, whether there are chances, depending upon the X-ray findings of the head, you can think in terms of whether there will be an avian of head or not, and depending upon the status of the hip joint, you can think about whether you need an MRI to confirm about the vascularity of the head of femur. And about the treatment plan, he will ask you what is your management option for this case. So these are the cases where you are dealing with the complication of a fracture. So you don't have a clear-cut definition saying this is the only way of treating this case. No, there is no hard and fast rule like that. So you will say that, sir, I will discuss with the patient, and the treatment plan depends upon the age of the patient and the quality of the bone which you have in the malunion site, and the status of the hip joint, whether there is already an arthritis happening over there in the hip joint, or there is a native normal hip joint is there, and the patient's demand, whether the patient is a young hard-working male who has a very high demand to his hip, the presentation and the management may vary. So what are the treatment plans we have for this malunited intertrochanteric fracture? Well, there are two categories of treatment for this case. The one is, since he is having a coxa vara, you try to neutralize the biomechanics, so you will do a valgus osteotomy. So valgus osteotomy is one of the treatment options. The other one is arthroplasty. You do a THR. So you first decide what is the age of your patient and what is the quality of the bone you have there and the status of the hip joint. If he is a young male having high demand on the hip and around young male around 30s to 40s with a high demand on the hip, you stick towards osteotomy only. There is, even though if he has an arthritis, if it is a 2-3 years old Malunited Intertrochanteric with arthritis, you can still say you can postpone the first arthroplasty option to him by saying that first you do an osteotomy, you correct the deformity, because there are some papers which say that if you correct the deformity, there are some chances for the head to even revascularize. There are papers like that. So we can give a chance to the native head to revascularize or do whatever that is possible to retain the native head of the femur in a young age. So you will say him that this is the first stage of your treatment, where first we will do this osteotomy and correct the deformity you have in the limb, so that we can you can postpone the first total hip or any arthroplastic options available for you for some 20 years back. So down the line, after 20 years, you may develop an arthritis, which is very concerning to you and which may need a secondary surgery, which doesn't mean that this surgery is a failure. It is the due course of the disease per se, and you might need future surgeries also. You can say it in that way and counsel him for the first surgery of osteotomy. This is for a young chap. Consider having a 60 plus elderly who is coming with a neglected Malunited Intertrochanteric. You have already a similar presentation, an arthritic hip, but the bone quality is not very good. And he's a smoker or some comorbidities also, diabetes, hypertension, some more comorbidities to add to the presentation. So for an osteotomy to fuse and then to give him a stable hip, it is even a better way to straight away take him for a total hip replacement and give him a pain-free mobile hip who doesn't have much of a demand on the hip, and so the longevity of the implant is not in a question. And down the line, he's already 60 plus. So he might at all need one revision if he is long enough to live for another revision also. So these are the two categories of treatment we have for this Malunited Intertrochanteric. So this is the treatment plan what we have for this case. So next, with this we finish the what category of the presentation. Now we will do what. Considering it as osteotomy is our option. That is valgus osteotomy. That is what I was saying before. Because he is having a coxa vara, we will neutralize it with the valgus osteotomy and the lateral limb by a closing edge osteotomy. So depending upon the location, it is categorized into two ways. Either you do it in the subtrochanteric region or you do it in the intertrochanteric region. If at all you do it in the subtrochanteric region, it is ideal to do a subtrochanteric osteotomy in a case of mild varus with no much rotational deformities and shortening is less than 2.5 centimeters. And moreover, subtrochanteric osteotomy is concerned only for cases with a very mild presentation, whereas if you go to intertrochanteric osteotomy, it is exclusively done for cases with more than 5 centimeters of shortening and gross coxa vara and more rotational deformities. Because the concept or the thing behind this regional variation is that always when an osteotomy needs to get united, it is ideal in the case of a metaphyseal zone compared to a diphyseal zone. So intertrochanteric osteotomy has a very good chance of union, and it doesn't have any inherent complication of non-union if you are doing for a gross deformity in intertrochanteric zone. Think if you are doing it in a subtrochanteric zone, since it's a cortical bone, the chance of union may be in question. So we are more inclined towards intertrochanteric osteotomy routinely in our practice and treatment. Subtrochanteric osteotomy, we do it only for very mild deformities which needs correction. These are the two osteotomies which we have in valgus osteotomy. So coming to arthroplasty, the moment you say arthroplasty, consider him as an elderly male, you are saying it as an arthroplasty. As sir was saying in the previous talk, whenever you say an answer, you must be prepared to the answer for the next question which is coming out of that also. So if you say an arthroplasty, this question was raised in the previous talk also. If he is having a coxa vara, definitely you will be asked about what are the complications you have while doing a total hip replacement. Sir was saying, as sir was saying, starting from the incision, positioning of the patient, everything will be it will be a challenging task to the treating surgeon. So in arthroplasty, what are the challenges you have? There is just for the procedure per se, you will have for concept-wise, even if you see, there will be a mismatch between the metaphysis and the diaphysis zone. Since it is malunited, there will be a mismatch. So your normal conventional metaphyseal filling stems will not be suitable for this case. And because of the malunion, you will have a medial border will be straightened. So the implant stem will not be accommodating. Your routine implant stems won't be accommodating that mismatch. And what are the solutions we have for that? For any proximal femur osteotomy or malunion case, which we treat with primary arthroplasty, these are the options available. Depending upon the severity of the deformity, you can either, if it is not much severe, you can go with the small cemented stems alone. And if it is more severe, you can go with modular stems like S-Storm stem or something. This is an S-Storm stem having all options to vary the dimensions and individual components of the implant depending upon the deformity or the adjustments you need. It is tailor-made for individual patient. And this is a case example of an S-Storm stem being used for malunited intertrochanteric fracture, for which an osteotomy is being done, and the osteotomy has united, and later he was having an arthritis of the hip. So the procedure was staged, and implant removal was done. He was waited for some time, and then after which he was taken for a total hip replacement, in which you can see that the S-Storm stem is being implanted, and these are the various components which has been exclusively used for this patient, considering the metaphyseal zone or the neck or the stem part. Everything will be customized to this patient depending upon the preoperative deformity which he is having after the osteotomy unite. Even for post osteotomy arthroplasty also, or even for a primary arthroplasty for a malunited intertrochanter. These are the options which we have. Next, coming to the how part, we will see how intertrochanteric osteotomy is being done. It is called a modified Powell's valgus intertrochanteric osteotomy. And coming to the procedure, how it is done. Any osteotomy, if you are planning for an osteotomy, it begins with the preoperative templating. So you must know how much wedge has to be taken for an osteotomy to be a success to achieve a natural, normal, biomechanical position of the limb for the normal functioning. So you will see what is the preoperative planning that is needed. That is the wedge planning. So if you look into this image, the first image shows, consider this case example has been given for neck of femur fracture. The same goes along with the intertrochanteric fracture also. So that is a fracture line that is marked in red. The 25-degree angle is the normal loading angle, which is ideal for a normal hip. So that is the 25-degree axis which we want to make out of this femur. So that is a 25-degree axis we mark over there, and then we mark a perpendicular to that axis, the 25-degree angle, that is marked as X. And Y will be the line of the fracture. Here it is marked with the neck of femur. So consider it as an intertrochanter also, it will be somewhat down, some 3 centimeters down. So it will make an angle with the X. So that will be the angle of wedge which you have to take in order to neutralize the neck shaft angle to have a 25-degree of loading force to the hip. So this is the way of, there are many ways of calculating this wedge. This is one of the way of calculating this wedge. Consider this one. Here the Powell's angle is 45 degrees. So the angle is 45. You want to make it to 25. So you take a wedge of 20 so that it is getting converted to 25. Here they have been using an angle plate. So they are using a 20-degree wedge to neutralize that 45 degree to get converted to 25 degrees. This is the way which we use an angle plate to correct and fix this osteotomy. One thing to say about this, the thing marked in arrow mark here, that is a place which is called an elbow of angle blade plate, where you will put the grafts from the wedge. You will have some bone stock where you can put the bone stock over there, and then which will facilitate in the union and also in compromising to the length and the natural nature of the bone which is being corrected. And this is about the preoperative planning. If you come into the intraoperative steps, how we will do this? First of all, there are many implants to fix this osteotomy. You can either have a sliding hip screw, DSS, or you can have a DCS, or you can use an angle blade plate. The thing with the implant which is ideally designed for this osteotomy fixation is angle blade plate. It's a single angle or dual angle blade plates. But angle blade plates don't have any room for error or miscalculations. So it has to be exactly placed so that the opposition of the bone and the angle which you achieve is exact intraoperatively, and there is no room for error. Whereas in case of DHS or DCS, there is a small 5 to 10 degrees of room of error which can be managed with this implant. So we are more inclined and we are more comfortable using either DCS or DHS, and angle plate plates are not in vogue in use currently. And this is an example with the DCS. First, you can see the guideway for the latch screw is being put in the head, and the wedge has been marked with K wires, and it is being here the guide wire is being put and the wedge is being marked with the K wires, and then the head screw is being put and the osteotomy is being made, and here the osteotomy is being fixed with DCS plate, and it is confirmed in the lateral view so that the position of the osteotomy and the neck is right and the screws are in the right place. And this is the post-op image showing union of the osteotomy and appropriate positioning of the implants after 6 months of the surgery. And these are the implants I was talking about. You have either an angle plate or DHS or DCS to fix these osteotomies. The ideal one which we conventionally use every day is DHS, and it has shown in various papers that it is equally good to the angle plates, and the results are comparably even with all the implants. So it is not the implant that is going to decide your outcome, it is the precision of the surgery which you do. Next to go about, we have prognosis. Since we deal with only the valgus osteotomy in adults, it is not the way in pediatric cases. So coxa vara is categorized into various types. We have either congenital or developmental coxa vara. Considering if the conversation goes in terms of pediatric population, the examiner may even deviate in that way and ask you that what is the prognosis if at all you do the surgery in a pediatric case, because it is most commonly done in pediatric cases. Either it's DHS or any DDS or any case of coxa vara, we do valgus osteotomy. So if you do a valgus osteotomy, there will be limb lengthening, and the shortening which you see pre-op in a pediatric case will be only around some 0.5 centimeters or 1 centimeter. Some very little shortening only will be there. But if you let the patient, you just follow the patient, he will invariably in the developmental stage, he will land up having 7.5 centimeters of shortening, even though he has a shortening of only 1 centimeter in the day of surgery. Which is because it is not that he is having a 5-cell damage and he is having any abnormality to the physis which is growing. It is not that. It is because there is no stimulation to the physis due to the abnormal biomechanics. So once you restore that with this osteotomy, it will be corrected. In case of intertrochanteric fractures in a pediatric population, the shortening is not the one which you get in the on table or a preoperative. It may worsen in the future if you don't address it. So if you properly address it and restore the biomechanics, there are chances to prevent this gross shortening which is happening in this adolescence if you attend it in the proper time. He is in a pediatric age itself. And coming to the adults, in adults, one more thing to contrast with the adults and pediatric population is maintaining the apposition or maintaining the osteotomy fixation in pediatric population is tough, and it is more prone to post-operative complications. So you always put a hip spica or some additional measures to make sure that your fixation is holding still and good until the osteotomy site unites. So that is not the case in case of adults. In adults, you can go with a partial weight bearing by 6 weeks and full weight bearing by 12 weeks, and it will invariably unite. Since you are doing it in an intertrochanteric zone, there is no complications with adult case of malunited intertrochanter which you are fixing with an osteotomy. Considering and coming to the prognosis, since it is a prognostic part, you are doing an intertrochanteric osteotomy for malunited intertrochanteric fracture. So you must also say him, as I was saying before, there are chances for AVN or secondary arthritis due to this chronic malunited intertrochanter which he was having. And this surgery is not a remedy for the arthritis which he may develop or which he is already having. So he might need another arthroplasty procedure in future, and this is the procedure to correct the abnormal biomechanics which he is having, and this will alleviate his pain and the deformity to the extent possible, and he might need a future surgery also. You might make him you must ensure that he is knowledgeable about that also, so that he might not be very anxious about his future surgery thinking this is a failure. And coming to the complications part, any surgery will have a complication. That here it may be either immediate or late complications. I will go with each. Coming to the osteotomy part, in osteotomy part, in complications, there are chances for AVN. It should be a late complication because you are going about, if you have an angle plate plate, or if you further muddle up with the vascularity of the head, you may have a chance of AVN, which is already compromised because of the fracture. It is not the primary procedure which is causing the AVN. It is the vascularity which is already compromised due to the fracture in the malunion, which is further compromised with the surgery. So that is a chance. AVN is a chance. And if you are going with primary arthroplasty, there are chances for intraoperative fractures, which is reported in various literatures also. And I don't want you to bombard you or submerge you with all the papers which is relating to this topic and confuse you or make no clear consensus about of it. So I am giving only the classical findings which you should say, and make sure you just get out of this case with good marks. That's all. And these are the coming to other late complications. If you are dealing with an osteotomy, as I was saying before, he might develop an arthritis and he might need a future surgery. And AVN is a complication if you are doing an osteotomy in future also. And about if you are doing a THR, he might develop, and he may need additional implants intraoperatively, considering if you are dealing with an SRAM or some kind of tailor-made processes for him. And intraoperative fractures are also a concern, and additional implants to manage and tackle them intraoperatively must be made prepared when you are handling out with this case. So, and various papers have noted that if you have a preoperative osteotomy being done for a patient at the proximal femur, it does not compromise the functional outcome of the THR which is done out of it. It is only the technical difficulty we will have during the surgery, and it is having no correlation with the functional outcome of the hip processes or the longevity. And there are many papers which are corroborating this finding in various instances. And this is a finding which I want to show you. In a post-osteotomized proximal femur is not a compromise. It is a definite primary THR, and it will have equally good results to that of a primary THR which is done for a normal femur. It is only the technical difficulty we'll be having, and all the special implants we'll be needing to get that normal outcome out of the patient. That's it. And these are the complications which you'll be having. And this is a nutshell about Mgmt intertrochanteric case which is being given in exams. And I'm open to questions. You can ask me any questions.
I want to add some 1 or 2 points. It's a simple case for a MS Ortho postgraduate student. So the questions will be somewhat from basic level to in-depth level, as we discussed in management aspects. So one point I want to add is how to differentiate clinically a fracture is a neck of femur or a trochanter. In this, the point the examiner they will expect is you have to look for the little toe, whether the little toe is touching the floor or not touching the floor. So if it is touching the floor, then it's a case of extra capsular fracture. That's a trochanteric fracture. If it is not touching the floor, that it is most probably a neck of femur fracture. So whenever you are mentioning in inspection, it is better to use the term the little floor is touching the floor or not touching the floor. That is one point I want to add. The other point I want to add is nowadays we are getting large number of non-union in trochanteric fracture rather than malunion. So you won't be surprised if you get a telescopy positive in a given case of malunited trochanter. So you may get a telescopy positive. So if you get a telescopy positive, then you have to explain that it's a case of basotrochanteric or a basocervical fracture. So it has not gone for a malunion, but has gone for a non-union. So these 2 points you may come across in a clinical scenario. You should be able to answer it whenever you are coming across this clinical scenario.
Okay.
Yes, very true, sir. I think in the confusion on the about non-union of trochanteric fracture, and some malunion of malunion varadu, but sometimes it can happen, valgus impacted neck of fracture, though very rare, but that is very rare, but definitely non-union trochanteric fractures. Many a time in exam we have seen a case, sir.
Yes.
And the one case will confuse the candidate.
Yes.
Candidate he'll be a very good candidate, sir. And the one difficulty whether to say it is a malunion or whether to say it is a non-union, he gets confused.
Yes.
And then the entire scenario will change.
Yes.
So yeah, that is very true. I think Dr. Tanapan by his experience is brought out, because every exam we see such a case. So on the one case you have to be very careful while giving a diagnosis. Do your test again and again, confirm it, and then only give a non-union trochanteric fracture. You have to be very sure that you are given a correct diagnosis. If you give a correct diagnosis, then you escape. If you give a wrong diagnosis, then you have to justify each and everything, which examiners might accept or they might not accept. So I think very true about all that. And
it was a very crisp presentation.
Thank you.
It was very nice, actually. Interesting. The way you presented was very nice, actually. So PGs might have definitely taken a lot of points from your presentation. I think it was complete. You covered everything.
In management aspect, I want to add one more point. We get a lot of examiners from North India, so they are very particular about a procedure called femuro-acetabular bypass. It's a popular approach in Maharashtra. So femuro-acetabular bypass, the postgraduates should know what is femuro-acetabular bypass. It's nothing but a hemiarthroplasty for a trochanteric fracture. So that's a paper published by an Indian orthopedic surgeon in JBJS. So those examiners who are coming from North India, they are very fond of this particular question, the femuro-acetabular bypass surgery. It's nothing but a hemiarthroplasty procedure for a trochanteric fracture, and it has its own points, merits and demerits. In the era of total hip replacement, it is not being done regularly, but it will be definitely asked in the exam if you are if the examiner is from northern part of India.
Tanapan and Dr. Ramprasad, I just want to ask one question. So when do you think you have to commit about the replacement? At what age group? And at what age group you want to say you want to do an osteotomy? Where is the cutoff point? At what age group I want to take a replacement? I want to do a replacement for this case. In exam, suppose the similar case comes in exam. So as an examiner, so what do you expect of the student? So when do you think you will be very happy if he says replacement, or you will be totally dissatisfied and you want to fail this guy because he said replacement?
Okay, my view is it's not depending upon the situation. It is all depending upon the student, how he is going to impress the examiner with the management purpose. Suppose he is selecting an option of osteotomy, then he should be having all the points for osteotomy for that particular patient. And suppose he is selecting a replacement for that particular patient, then he should have all the merits of that surgical procedure. You should be confident of the procedure. That is the main point I want to enlighten. So if the student is confident enough in discussing any management, I think most of the examiners will agree. So it is not the question of selecting a particular management for a particular patient, rather than it is the question of the student who is presenting the case, who is having the confidence in taking a particular management and withstanding with it. This is my view.
So he must be able to justify his management.
Yes.
Ramprasad, what is your view on this?
To add to Tanapan sir's views, actually every examiner will have something behind his mind that the candidate is expected to answer. But as Tanapan sir told, the candidate should be able to justify and substantiate whatever he is going to opt from the particular options, actually. But what I feel is, for an younger age group, as he said, osteotomy would be a better option. And for and the delineating mark you are asking, what is the age group beyond which you have to answer total hip replacement? I feel that 50 would be an ideal thing, and we have to look for the physiological age also, not only the chronological age. We have to take into consideration the physiological age of the particular patient. so that even nowadays many of the people are doing bone conserving procedure like fixations in elderly age group also. Even for a neck of femur, people are doing fixation even at the age of 60 years. So only after the age of 60 years they are going for THR. So up to 60 years fracture neck of femur, they are fixing. Many people are there fixing the bone conserving procedure. So in that aspect, if you see, and you have to also say that I'll discuss with the patient what he is demanding actually. So as he already told in his presentation, the demand of the patient also should be taken into consideration. And if the patient is hardworking laborer, then I don't think arthroplasty will help. And if he's willing to change his lifestyle, if he's willing to change his work, job, then we can go for arthroplasty. Otherwise, arthroplasty would be a disaster for a laborer. And in those patients, we have to manage with osteotomies and procedures apart from this total hip replacement. And for people who want to fully flex their hip and this thing, some people may accept instability and they may want more movements of the hip joint, particularly flexion. So in those patients, an excision arthroplasty also might be a good option if there is a severe pain at the hip joint because of arthritis. So individualize the patient and individualize the treatment based on the patient. Whatever the patient demands, you have to consider, and based on the demand, we have to decide whatever. We have got a lot of options in the bucket, but what we have to decide is only based on the patient's demand and the willingness for his change in lifestyle.
And
final.
I just want to ask one more question. Say one more question is, in the spectrum of what Muthu Sathish had taken, he had gone from osteotomy to arthroplasty. So, but I think many cases I've seen 65, 75 where we don't have cases. This Malunited Intertrochanteric cases poorly walks in on the OP and our exam. So you want to suggest a conservative management and just escape out? Yes, so surely. I think on that spectrum, I think you just left behind only one thing, that is conservative management. Because most of the time, these intertrochanteric fractures are very, very comfortable. Okay, they just walk in, or you have address and phone numbers of these cooperative patients who keep coming from exam to exam. So conservative option, I think the PG also has to have an option of conservative management also. And as Dr. Thanapan said, to escape out of his justification, then definitely I think conservative management. And sir, if it is a conservative management, Rampal sir, and Thanapan sir, what will you advise? Where to keep the stick on the right side, heel raise, to what extent of shortening they can accept, if you want to give a conservative management. So what is the point where you think conservative management will work on this patient? When? So whether you are, and how you manage him conservatively, you give him a walking stick, what kind of training you do?
No, once again, the same thing. We have to take into consideration the demand of the patient. So most of the patients who are presenting with malunion will be uneducated and coming from a lower socioeconomic group, because the person who is well informed and who is knowledgeable would have definitely landed in a hospital and would have get operated. If he has not get operated, that means that these people are like buffaloes. They don't want any treatment and they go for native treatment. They are all not willing for any surgical procedures. Therefore, as you said, most of the patients will be happy with conservative treatment if they are not given the option of surgery, because surgery is always the patients as well as their attenders are struck with awe when you suggest a surgery for these village illiterate patients. So they will be very comfortable with, and as you said, if there is a pain in the hip, that's the only problem. Shortening can be managed with shoe raise, but the pain, if there is there, then we have to go for stick cane management. And as you said, the cane would be better held in the opposite hand, actually. Opposite hand. Opposite side.
Opposite side. Okay.
Yes.
Sir, Ninga, you want to say something, sir? Muthu Sathish, you want to say something on the
conservative management? If the patient doesn't have much of a shortening, either it's 2 centimeters, you can manage it with the heel raise. And as a hip pain manifests, you can substitute it with the cane on the other side, as sir was saying.
So my question is, why hip pain in Malunited Intertrochanteric? Because you are all concerned about hip pain. Dr. Rampal also mentioned hip pain. You also mentioned hip pain. So what do you think will be the reason for hip pain in a malunited intertrochanteric fracture?
It is an altered biomechanical action of force on the head of the femur, which is causing an arthritis. That is the reason behind the hip pain. And the purpose behind the osteotomy is to neutralize the altered biomechanics. That is why we are doing the osteotomy, to correct the angle in which the forces act on the hip. If it is altered, then definitely he will have an arthritis and hip pain.
So after intertrochanteric fracture, so how long do you think, how later is he going to develop an arthritis? Because arthritis per se in a malunited intertrochanteric fracture, normally we don't see that much.
We don't see that. It is a late presentation. It is not an early complication.
These are very late presentations. Once you develop arthritis, then there's no question of osteotomy. You're not going to realign with the,
we are straight away going to address the hip.
So once you see arthritic changes, then there is no question of replacement at all. I mean,
question of osteotomy
at all. So I also invite the other postgraduates if you have any questions, because it's a very simple topic, but they will expect a very straightforward answer in this. There's no confusion or ambiguity in your exam during this topic, because it's a very one of the easiest cases. So you have to answer all the questions properly. So we have 2 other professors in this, and who have been a lot of examiners. So I invite all the postgraduates to go ahead and ask your doubts if you have. Even if it is a simple doubt, it's all right.
Sir, Chairladan here.
Solunga.
Sir, I would like to add just one more point to the management option with cane, sir. There was one examiner who was asking me, actually in my postgraduate exam, I had a similar case, and when the discussion went about conservative management, and I gave the answer as using a cane on the opposite side. And he asked me, is there any other option other than cane? The patient doesn't want a cane, but can you give something else which will act in a similar way? The answer is carrying any weight on the ipsilateral side, sir, like a suitcase or a bag which has some amount of weight on the same side. The mechanism is the same. It will offload the hip like the cane on the opposite side, but carrying a bag on the same side, it will also offload the hip and help the patient, sir.
Okay. I think he wanted you to think really. If you had given, did you give that answer?
No, sir, no, I didn't answer this during the exam. After the exam, I came and found it out.
Okay. No, if you had given that answer, maybe you would have given me first mark. So other PGs also, I think you can ask Jordan, Varadarajan. Kelungappa. So if you're very, very clear about this, you close you have any other doubts, just go ahead and ask your doubts.
And I would like to congratulate the speakers. It was a very clear presentation today.
Hello.
Hello, sir. Sir, one minute. Sir, suppose if we have a case of non-union intertrochanteric femur, whether there is irregular and thickening on palpation is present or not, sir?
It will be present. It is a trochanteric fracture.
No. What he means.
That's a very good question. Between a trochanteric non-union by clinical examination itself is an interesting topic. Actually, the point you asked is how to differentiate. If you hear for broadening, if there is a broadening, that's a telltale sign of malunion. If it has broadened, that a trochanter has gone for a malunion. So you have to look for broadening of the trochanter. If the broadening is there, that's a telltale sign of malunion. Without broadening, there is only irregularity or some local thickening or some gap in between the trochanteric surface. Those are all points in favor of non-union. So you always for a broadened trochanter and you compare it with the opposite side. The problem with looking for broadening is the trochanter will be some distance externally. So internal rotation will mask the broadening. So you have to always keep the limb in a neutral position. Then you have to palpate the trochanter. Then only you can able to appreciate the broadening. Otherwise, you're missing the broadening. You will be thinking that the trochanter gone for external rotation. So this broadening is the important differentiating point between this malunion and union.
Thank you, sir. I think it's a good point. Broadening on the definitely mentioned one, but non-union broadening on the I think is a perfectly valid point.
Moreover, Thanapan said initially, I think he has told the answer also. In neck of femur fracture, the shortening will be lesser. Yes. Whereas in trochanteric fracture, the shortening will be more. Because, as he said, neck of femur is an intracapsular fracture. The the intracapsular position of the fracture will prevent the high raiding of the trochanter. So the shortening will be just 1 or 1.5 centimeters. Whereas in trochanteric fracture, we can expect more, up to 4 centimeters.
His question is how to differentiate.
No, that's what I am saying.
Malunited
How
and
to differentiate between neck of femur non-union?
No. That was not. Question was how to differentiate between malunited intertrochanteric fracture and a non-union intertrochanteric fracture.
There comes the telescopy.
The telescopy will different. But அது malunion நீங்க non-union எப்படி சொல்றீங்க? Trochanter எப்படி சொல்லுவீங்க?
அதுதான் நான் சொல்றேன். trochanter இல்லன்னா neck தானேங்க. Trochanter இல்லன்னா neck. You want to differentiate between neck and more. Shortening will be very shortening will be too much in trochanteric fracture. Almost say 4 centimeters shortening can be expected in trochanter because it is an extracapsular fracture. There is nothing to hinder the overriding of the trochanter. Whereas in a neck of femur fracture, the capsule will hinder the proximal movement of the trochanter. Therefore, the shortening will be minimal. 1.5 to 2 centimeters shortening may be expected maximum in neck of femur fracture.
Point well taken.
I have a doubt, sir. Sir, in neck of femur fracture during telescopy, we can appreciate the trochanteric movement, sir, but how can we expect that movement in a telescopy in non-union intertrochanteric fracture? Because there we can palpate and see whether it is moving or not.
So I think
Okay,
Ramprasad
that's another very good question.
Or Danaprasad will answer. So I have some support today, sir.
That's a very interesting question. Actually, that's a very good question. Actually, the telescopy for neck of femur and telescopy for trochanter is entirely different. So, you know that in telescopy, you have to look for two movements, both push and pull. So, in trochanter, classical neck of femur fracture, both this pull and push will be positive. So, you'll be able to push the fragment as well as able to push the thigh. So, both push and pull will be very classically present in a neck of femur fracture. Whereas in a trochanteric fracture, because of the some fibrous union or some kind of fibrous adhesion between the fragments, you may not be able to go for a push. So you have to rely on your pull. You have to rely on your pull technique to look for the telescopy rather than to go for a push technique, which is very classical in the case of neck of femur fracture. So that will come by experience. As you start seeing more and more neck of femur non-union trochanter, then you will be able to differentiate the telescopy for neck of femur as well as for trochanter.
Non-union trochanteric fracture is not very common. So எடுத்த உடனே போயிட்டு non-union trochanteric fracture think பண்ணாதீங்க. முதல்ல don't think out of box.
That's okay.
Okay. First malunited னே வெச்சுக்கோங்க. Then you see the subtle points. Okay. Sir சொன்ன மாதிரி widening. Then reduced amount of telescopy. All these things you have to slowly, these subtle points you have to think and then answer. I think before you do that diagnosis, make sure that you are doubly confirmed all these points. உனக்கு எக்ஸாம்ல சொல்லும்போது இந்த பாயிண்ட்ஸ்லாம் நீ சொன்னேன்னா definitely it will be well taken. Sir, இந்த பாயிண்ட்லாம் பேஸ் பண்ணி தான் அப்பனா கிளியரா சொல்லிடுவாங்க. எக்ஸ்ரே பார்த்து தான் சொல்லிட்டான். Somebody has given a clue. So to avoid that situation, you tell them these are the subtle points that I've seen, sir. Non-union is not very common, but my observation was like this. I want to go in for a non-union trochanter. உனக்கு நான் உனக்கு என்ன கேஸ்னு சொல்லிட்டானா கூட அங்க போய் சொல்லக்கூடாது இதுதான் எனக்கு அப்படின்ட்டு. You have to justify your diagnosis and justify your treatment. So that is more important.
So even if telescopy is not that much appreciable, can we say it's non-union because of the SLRT test? Because we cannot do SLRT after that period of 9 months. So can I substantiate it as a non-union?
No. SLRT is not going to give it's not the criteria for giving a diagnosis of non-union. So that's not going to help you in clinical examination. So whenever you are going to give a diagnosis of non-union trochanter, you have to be doubly sure. You have to be doubly sure that it is non-union. Then only commit. That means the only way to appreciate non-union is for telescopy. So the examiner should get convinced by telescopic test. You should be convinced that there is a telescopy positive. Then only it can be considered as a non-union. Without getting a telescopy, you will never get a diagnosis of non-union trochanter. So the telescopic is very, very important. This SLRT will not hold good in exam.
So exam suppose there is a non-union trochanter, we keep it a very rare case. Suppose a non-union trochanter, what do you want to present it as? You want to present it as Coxa-Vara, or you want to present it as an unstable hip? What will be the anatomical diagnosis?
Yes. Hello.
Yes sir. Unga then sir.
Yes.
So what do you think?
Again, again, for giving a diagnosis of non-union, again, as you said, there should be telescopy. So without telescopy, you cannot give a diagnosis of non-union. So once you are able to appreciate the telescopy, once you are sure that there is telescopy, then the diagnosis of Coxa-Vara are gone. Then you have to go for unstable hip only.
Yes, sir. These are some basic doubts they will have, sir. Exam lo poi Coxa-Vara non-union intertrochanteric fracture sollalam. You know, this totally contradictory things which they will go and say in the exam.
Coxa-Vara, you always keep in mind 3 points. There should be true shortening. That is the first point. There should be true shortening. There should be restriction of adduction over adduction over adduction. Adduction is more abduction and extension is more than internal rotation. And preferably, there should not be a fixed deformity. These 3 points should coexist to give a clear-cut diagnosis of Coxa. There should not be a preferable fixed deformity. But malunited trochanteric அந்த மாதிரி எல்லா சமயம் இருக்க முடியாது. ஃபிக்ஸட் டிஃபார்மிட்டி இருக்க கூடாது. அடக்ஷன் வந்து எப்பயுமே அப்டக்ஷனோட கூட இருக்கணும். எக்ஸ்டர்னல் ரொட்டேஷன் எப்பயுமே இன்டர்னல் ரொட்டேஷனோட கூட இருக்கணும். அண்ட் தேர் ஷுட் பி ட்ரூ ஷார்ட்னிங். இந்த 3 பாயிண்ட் இருந்தா மட்டும் தான் நம்ம வந்து அத வந்து வரன் முடியும். வேறஸ் அன்ஸ்டேபிள் ஹிப்னு சொல்றதுக்கு there is only one point. That should be telescopy. Telescope கிளாசிக்கலா இருக்கிற எல்லா கண்டிஷன்லயும் you can very well go for unstable hip. அத வர வேற என்ன டயக்னோஸ் கிடையாது.
Yeah. So somebody wanted to come out with some question, I think.
Sir, what about the movements in non-union intertrochanteric fractures?
No, it will be exaggerated. Definitely, see, it is not a classical Coxa-Vara where there is restriction of abduction and internal rotation. Definitely, it will be slightly more only. It won't be as much as what it is in neck of femur, but it will definitely, some fibrous union will be there. It will allow you not that much of exaggerated movements, maybe a reduced amount of exaggerated movements. So don't get carried away with this non-union intertrochanteric fracture. Just don't get carried away. Stick on to malunited intertrochanteric fracture, and always have at the back of your mind, and just at the back of your mind, a situation where a non-union trochanteric fracture can also come. So I think, yeah.
Sir, sir.
Another basic question now.
Yes.
Agni, please wait.
Okay.
Basic question now. What is the common presenting symptom with which the patient will land in a case of malunited trochanteric fracture?
Limping and shortening. Shortening and limping will be presenting.
So the limping is a painless limp. That is what I would like to say. So most of the patients will not have pain. They will be walking, but they will have shortening. That's all. So that is the reason they will be coming here to the hospital. Otherwise, what is the complaint the patient has to suffer from? Because as we told, as a malunited trochanteric fracture, there is no arthritis in the hip. Why should there be a pain in the hip? If there is an arthritic etiology, then that's a different story. So 2 diagnoses will come. Otherwise, the patient will have mainly a painless limp.
Limp and shortening.
Gross shortening will be there. This is the reason the patient is going to land in the OT. So treatment protocol should be based on those symptoms only.
Yeah, he wanted to ask. Agni wanted to ask a question.
No, sir. Good evening, sir. Good evening, sir. The presentation was very nice, sir. This is the first time I am seeing the presentation like this, sir. As you said, the speaker was very confident, sir. I want to add only one mnemonic, sir. Sir, is it audible, sir?
Okay. Yeah, it's audible.
I joined only late, sir. Since you are discussing about neck of femur and trochanteric fracture clinical diagnosis, you can say whenever we say neck of femur, we say it is intracapsular and trochanteric fracture is extracapsular. So the mnemonic is in extracapsular, everything will be extra. The thing is, age is extra. It is more age group and it is extra common. So trochanteric fracture is extra common than neck of femur, and the external rotation is extra. As Tarapan sir told, external rotation, and the shortening will also be extra. So shortening will also be more. Extra means it is more than neck of femur. That's what I want to mention. And the union is also extra. So it is extracapsular, extra age, extra rotation, extra shortening, and extra union. You can remember easily clinically. This is we usually for teaching of undergraduate, but you can also remember easily. Thank you, sir.
That's very easy, It's extra easy to learn and extra easy to remember technique. இல்ல சார் வித் அக்னிராஜ் அரௌண்டியோ இந்த நிமோனிக் நிறைய சொல்லிட்டே இருப்பா சார். சொன்ன நிமோனிக் வந்து எப்படி ஞாபகம் வச்சுக்கணும்னு ஒரு நிமோனிக் சொல்வாரு. So this mnemonic was very easy, so it is easy point for a candidate to take through, sir. So if you have any doubts you can ask or we'll complete. So sir, Wednesday we'll have Professor Thanapan's talk on management of basic cervical and trochanteric fractures. Is sir? Am I correct?
Yes.
Yeah.
So we'll cover the basic trochanteric or basic cervical fracture in that lecture.
Yeah. So it will be very interesting talk, and he's a wonderful speaker, and he different. He's உங்களை பார்த்த வரைக்கும் உங்களோட அப்ரோச் டோட்டலா டிஃபரெண்டா இருக்கு சார். So he does very from basic to all the advanced level he'll go. And Prabha, you wanted to ask question. Prabha,
yes sir.
Yeah, come.
Sir, yes sir. So only thing is, suppose last time in my presentation, sir, one of the PG asked, suppose if the option is given, which is good for younger individual, whether osteotomy or straight away go for arthroplasty for non-union neck, means you said we can suggest osteo, but arthroplasty is the best option, you said, sir. But in the case of intertrochanteric fracture, malunited, younger individual, if the suppose option is left to the doctor, the patient say, okay, I need a good hip, that's all, means what procedure you will suggest? Whether osteotomy or arthroplasty, sir?
Yeah, this was the question I first asked to both the panelists today. So the patient surrenders to you, an young patient. What is your age? I mean, young patient in the sense, what is the age of the patient? So what's the age that you want to say? Young patient means?
Suppose less than 50 years, sir. Just a cutoff. 20 to 50 years.
Less than 50 years, I think there was a general consensus that osteotomy will be the answer in exam. But if you say replacement, you have to justify your answer.
Because
you should have the points to justify your answer.
Yeah, because a devastating fracture.
No, the examiner, like, younger examiners like Dr. Thanapan or Ram Prasad or me can accept, no issues. Provided you say, justify why you want to say. So அதுக்கு எந்த டீச்சிங் பண்ண முடியாது. அதுக்கு we cannot teach.
Okay.
That was what Dr. Thanapan and Dr. Ram Prasad had answered before. That was the answer they gave.
So among the osteotomy, which osteotomy is best? Depends upon the fracture pattern. Intertrochanteric or subtrochanteric? You mentioned intertrochanteric as well as subtrochanteric.
Intertrochanteric is the one which is ideal, sir, because that is a metaphyseal zone where we don't have any option of non-union of the osteotomy site. So we conventionally do osteotomies in the metaphyseal zone intertrochanteric only.
Okay, sir. But angle blade plate nowadays, most of them using DHS. Is there any comparative article which is better or superior or equivalent? Angle blade plate with DHS. Hello?
Both have a comparable. Sir, I'm audible?
Yes, sir. Yes, sir.
Yes. The blade plates are actually designed for this osteotomy purpose only, sir. But conventionally, as we do, there is no room for error if we use a blade plate. But in case of DHS or DCS, we can have some room of error. Moreover, the outcomes which we get out of this blade plates when compared to that of the DCS and DHS are comparably good. So it is not to say that one is superior or inferior. The functional outcome which we get out of these implants is all right. They are comparable only, sir. It is not inferior. The DHS or DCS is not anyway inferior to blade plates.
I think Muthu mentioned very clearly in his presentation. It's not about the implant.
Yes, sir.
About the technique. It is about the technique and how well you perform the osteotomy, how well you fix it. I think that will give you the results rather than what implant you use. That was the very clear-cut message that he had given already.